Welcome to the Functional Relations Podcast, where we set aside time to have engaging conversation. I had to swallow halfway through.
Yeah, man. Just take a deep breath before, so you're gonna.
Okay. Welcome to the Functional Relations Podcast, where we set aside time to have engaging conversation on relevant topics related to behavior analysis. I'm Zachary Bird.
And I'm Caleb Davis. How you doing today, Zach?
I'm doing well. I am a little bit sleepy. I had maybe 7 to 8 hours of sleep last night. And, to be honest, I don't think that's enough for me.
Yeah, I like between 8 and 9. That's my ideal.
Yeah, that's the sweet spot for me too. Like if I go to bed, so there's 9 hours before I have to wake up, that's good because it takes me 15 minutes to fall asleep. In the end, that turns out to be about the right amount of sleep for me. So I'm a little sleepy, but how are you doing?
I'm doing well. I got enough sleep, so I'm feeling good. I'm feeling energetic. So if you're listening, you might be like, why are these guys going on and on about sleep? It's because today's episode is all about sleep and the treatment of sleep problems.
That's right. Well, they actually knew that because they downloaded the episode knowing that the title of this episode was sleep related.
Right. So yeah, people actually aren't surprised.
They got the clues. They're like, this is a little bit annoying, but they got it. Yeah, they get it. Yeah, so sleep, this is a fun topic. I've learned a lot about it in the last maybe like 3 or 4 years, and it's one of the most interesting topics to me in behavior analysis, like recently, I guess.
Yeah, I know. I agree. I think this is a really interesting topic, and I've kind of been exposed to this area, I'd say probably also like within like the last 3 or 4 years in 2 ways. One, Zach, you and I actually had a doctoral class together. The class was behavioral medicine, where I think 1 week we talked about the treatment of sleep problems. And then also in the grad...
Yeah, we had Dr. Sandy Jin. She video conferenced with us during the class.
Right, yeah. So she basically...
That was cool.
She kind of was like the co-instructor, whatever you want to say, for that class. Because I think she lives in California, and we're on the East Coast. Right. But yeah, she was kind enough to attend our class and share like some of the work she does and the research in that area. So yeah, it's a really cool topic. And I know in the behavioral assessment class that I teach, I assign my students I think it's Jin et al.
Yeah.
The paper that's kind of like a seminal study that came out with Hanley's group there on the assessment and treatment of sleep problems. Yeah,
that's cool. I think it's really valuable. I think that, it might not be something that is foundational in the kind of, course sequence material that needs to be trained to all the new BCBAs, but it seems like a really good area for our field. Like we could be jumping in on this as like a really important piece of what we do.
Yeah. And I think what's cool is, I think sometimes when people think sleep, they think like, oh, well, that's not behavior, or maybe as behavior analysts, we can't really, that's outside of our scope. But I think that's not necessarily true. There's research out there showing that, we can, from a behavior analytic perspective, improve sleep if you think of falling asleep as behavior, right?
Yeah. Falling asleep as behavior. Sleeping itself is its form of behavior, but also the reinforcer, presumably, for falling asleep and the behaviors associated with that.
Yeah, and I think our conceptual framework is really valuable when kind of assessing and treating sleep problems, because when we think of like, antecedent stimuli like discriminative stimuli and motivating operations, those are super relevant and important when you're thinking about treating sleep issues.
Yeah, with antecedent stimuli, if you think about like the stimuli that are associated with you falling asleep are super valuable. And I know this because, if I ever go to like a hotel or something and I don't have my pillow, or, I'm looking at, an alarm clock that's not usually there or whatever, it makes it hard for me to sleep. Maybe I'm more sensitive than most people or something, but it really does make it hard for me.
Now, I think a lot of people are dependent on different stimuli to fall asleep. I know I like a fan or some sort of background noise.
Uh-huh.
And actually, more recently, the fan that I usually listen to broke. So I downloaded the app, a fan app, on my phone. And so now it's like I just turn on my fan app on my cell phone. And what's cool about that is I'm thinking ahead and I'm like, oh, if I'm at a hotel, if I'm like somewhere, I can always have that, assuming my
Yeah.
phone is charged.
You have a small fan
Yeah.
that you can carry in your pocket.
That's right. I could fall asleep anywhere. Just pull that thing out and fire it up.
Oh, yeah. So I think with my son, we use white noise and it's for the same exact reason. We can turn it on our phone or whatever, and wherever he's, we used to turn on our phone with white noise. We'd stick it in his stroller, and he'd be out, or in his car seat if we're driving or wherever. We just put it. We try to associate, because essentially the idea is the more we associate sleeping with these stimuli, the more likely that those stimuli will occasion sleep. And so we want a high probability of this stimulus being present and sleeping occurring, and that helps.
Right. So that's kind of like from the, I guess, like the discriminative stimuli perspective, but also motivating operations obviously play like a huge role when you think about like sleep treatment and maybe why somebody's not sleeping. And I think that also kind of informs some of the like the function-based treatments for sleeping, right? So like if you're quote unquote not tired, sleep isn't very valuable versus
Right.
if you are very sleep deprived, that's going to make sleep like as a reinforcer more valuable. And so presumably if you're trying to establish like a new sleep routine and get in basically falling asleep quickly, you probably want a strong EO in place for sleep.
Yeah, don't take those afternoon naps, Caleb. It's no good.
I try to not take naps as much now, knowing, especially if I know that I need to be able to fall asleep quickly, so I'm not up because I have to like wake up early the next day or something.
Yeah, right.
I'll purposely, even if I'm really tired, I'll say, I'm just got to power through because I want to be able to like fall asleep as soon as I hit the pillow that night.
Yeah, that's right. And I think a lot of the folks that I've worked with that have had sleep problems, sort of ends up that a lot of the sleeping is occurring during the day because the people couldn't sleep at nighttime. And so then when you're trying to, set up good habits around it, it's hard because people are not tired when they're supposed to be tired. And that's how it kind of all gets mixed up. So I think that we have these SDs with these stimuli that should occasion sleep. We have the MOs that make sleep valuable at the time in which we want people to be sleeping. And then, what about consequences?
Yeah, I think one thing that's really important, and I know it's like incorporated in some of like the assessment of sleep problems, is looking at maybe sleep interfering behavior. Or one way to maybe think about that too is like, are there competing reinforcers with sleep, right? So if I'm getting ready to go to bed, but at the same time, I'm like playing on my phone, that reinforcer of whatever I'm doing on my phone might be competing with sleep. And so that's not good. We kind of want to like eliminate these alternative forms of reinforcement for sleeping. If you have a kid who you're like, I wish they would go to sleep, and they're just playing on their iPad to all hours of the night, it would make sense why, right? Like maybe the iPad is more valuable than sleep.
Yeah, and not just kids. I feel like this is a huge barrier for adult sleeping. A lot of people who I talk to, it's like maybe Netflix is competing, or this is why I plug my phone in across the room, because I found that I'll wake up at like 3 a.m. and I'll be checking my email. And it's like, what are you doing?
Yeah.
Like, come on. So Android has this wellness app or whatever. And so it basically goes on do not disturb at 10 p.m., which hopefully I'm in bed before then, to be honest. And then I think it goes until 6:30, and I plug it in across the room. So this has been really useful for me. I think I caught on pretty early with that, as far as like knowing that was not a good thing for me. So Yeah, so there's sleep interfering behavior. What else with consequences? Anything?
It kind of goes along with sleep interfering behavior because it can be sleep interfering, but possibly like social consequences that compete with sleep. So maybe like, kids that are getting out of their bed or like want their parents and things like that. How people respond to those types of behavior matters, right? So I
Mm-hmm.
think I feel like the way we're framing that, it would be like automatic reinforcement, like as you're playing with your iPad, versus maybe a child wanting their parent around, and if the parent provides like attention or other fun things, that could compete with sleep or
Yeah,
interfere
that's
with
right.
sleep.
Yeah, so that's a good kind of, I think, foundational understanding of the conceptual framework around why behavior analysts can and should get involved with sleep treatment, don't you think?
Yeah, exactly. And I think that, like anything, it requires an assessment of the issues, like the context it's occurring, what variables matter. And so, I
Right.
mean, I think that's something as behavior analysts we're trained to do. It's just kind of looking at it a little bit differently, but it's the same kind of stuff, that we've been trained to do.
Yeah. Okay. Cool. Yeah, so I think with this episode, we should find someone to interview that has a lot of experience with treating sleep problems and someone who kind of has a real good foundational knowledge of the seminal research in the field, and then we'll see how are they treating sleep problems.
Yeah, let's do it.
All right, cool, let's do it. Hello, Dr. Moore. Thanks for coming on the podcast today.
Thanks for having me.
Yeah, today we're talking all about the treatment of sleep problems, and you're somebody who knows quite a bit about this topic. So, would you mind just to start out by maybe taking a minute to describe to our listeners how you got into this area?
Sure.
Dr. Keira Moore is the founder of Moore Behavioral Consulting and an adjunct faculty member at Regis College in the online program.
I started learning about sleep in, I want to say 2010. I might be off by a year. In the PhD program at Western New England University, I was in a class with Dr. Greg Hanley, who I'm sure most of your listeners are familiar with. And we had one whole week's worth of class that was devoted to covering sleep and how do we treat sleep as behavior analysts? What kind of research is out there? How can we conceptualize sleep as behavior? And I really liked the way that Greg taught us about it and his approach to treating sleep problems. And that was shortly after he developed his sleep assessment and treatment tool. So he introduced us to that. And I was super excited by the idea of using that and using the treatment methods that we had talked about in the class. So right away, I took that and kind of ran with it. And I was working for a consulting agency at the time and started doing a little bit of sleep work here and there with my clients. And then more people started hearing about it and more people started asking for it. And I started getting a lot of consulting work just on sleep cases. And I've kind of just taken that and run with it for the last 10 years now.
Oh, that's pretty cool. That's a great origin story. Caleb, have you ever heard of Greg Hanley? I don't think I have. Maybe.
Sounds familiar. I have to look him up after the episode.
Yeah, we'll make sure to Google Scholar him. We were wondering if you could just kind of briefly summarize some important or seminal research in the area. You did just mention Greg Hanley's sleep assessment tool. Is there anything else that's kind of influenced your way of thinking about sleep treatment?
Yeah, so my first introduction to treating sleep problems and assessing sleep problems was that sleep assessment and treatment tool. And the first place that really pops up in the literature is in the Ginn, Hanley, and Beaulieu 2013 article, which is an individualized approach to treating sleep problems in young children. So when I first started being introduced to treating sleep problems by Greg and his group and Sandy Ginn, who is a friend of mine, they were working on this research and I got to see a little bit of what was going on and see some of their data. And I found their approach really interesting because they were the first that really did an individualized approach based on that sleep assessment and treatment tool. And I really liked how they were designing these individualized treatment packages for kids that seemed to be working really well. So that's what I've based a lot of my own work on, is that sort of approach. But there's a lot of earlier research that their approach is based on. So Greg would always be the first one to say that they didn't invent anything new other than the sleep assessment and treatment tool, that all of his approaches to treating sleep problems and all of his conceptualization of sleep problems came from the literature. And they did a really good job of being really thorough in their literature review. So for me, some of my favorite articles on sleep, I think one of the best ones that really helps us understand how we can even look at sleep as behavior analysts and how we can understand how to treat sleep as behavior, comes from Blampied in France in 1993, and it's called A Behavioral Model of Infant Sleep Disturbance. So they were specifically treating infant sleep problems. And they did a really good job of really laying out how we can analyze sleep as behavior, and that we can look at sleep as not behavior in and of itself, but as this sort of biobehavioral state. So they sort of liken sleep to something like pregnancy or digestion, where it's this thing that's happening in our body, and it's not something that we can change through reinforcement per se, but it is this sort of behavior-like state.
Yeah.
So in that article, they do a really good job of laying that out and then talking about how sleep as this biobehavioral state is actually the reinforcer for the behavior of falling asleep. And they talk about what they call behavioral quietude as being the behavior that leads up to falling asleep. So they kind of conceptualize it as this whole chain of responses from the time you start getting ready to go to bed all the way up until you're laying in bed and you have this moment of behavioral quietude, and then you fall asleep and then you sleep. So they explain how you can still treat that as a behavior analyst. You can still look at sleep as a behavior problem. You just have to look at the SDs and the EOs that occasion falling asleep, and that's going to be our target behavior when we look at sleep. So using that whole model as a reference is how you can really start to then think about, okay, well, what are the environmental variables that I can manipulate then, and how can I actually treat this as a behavior problem? So that's
awesome.
One of my favorites.
That's a good example. Yeah.
Yeah. And then there are a couple other, I would say one of the best sleep ones that probably a lot of people have heard about is the Friman et al. 1999 paper, which talks about the bedtime path.
Yeah.
One of my all-time favorite sleep strategies to use. And probably one of the most famous behavioral sleep strategies that comes from our field, because Pat Friman does a fantastic job of getting out there and promoting the things that he's doing and making them really easily accessible to people.
Yeah.
So that's a technique that I really like and that I like to use in my own practice when it makes sense. There is also a study by Piazza and Fisher in 1991 where they talk about fated bedtime and response costs. So that's kind of changing the sleep schedule at night to make sleep more likely to happen. And it's just a really easy, simple manipulation that you can do where you change the bedtime schedule and makes a really huge difference in kids' sleep problems. And that's another thing that I incorporate into a lot of my practice. So I think those are my big four.
Oh, yeah, that's awesome. Those are great resources. We'll make sure to put those in the show notes for people if they're interested in looking into those. Seems like the 1990s was a big decade for sleep research, and then it went from there. That's quite recent.
Yeah, I'm not sure what was happening in the 90s that people needed sleep treatment so much.
People were very tired.
Rough time. I guess that's when we started getting the internet and video games, screen time.
Right, that's what it was. Super Mario Brothers. And people just ruined people's sleep. And they're like,
sleep really took a hit. Yeah.
Yeah. Must be.
Yeah.
When I was in grad school, particularly the master's program, I don't think I learned that much about sleep. We might have read like an article or two. And I feel like that might be kind of typical for students as they're going through master's programs. There's obviously a ton of content that you have to cover. Why do you think it's important if somebody has a BCBA to kind of learn more about treatment of sleep problems? Like, what are the advantages to that, do you think, everyday practitioners?
Yeah, I think similar to your experience, I didn't even realize that sleep was something that I could treat as a behavior analyst until I took that class with Greg. And that was sort of a light bulb moment for me where I was like, oh, wait, that's something that I can handle in my practice, and that's something that I can help my clients with that I had never thought about before. I didn't think of sleep as behavior, much like probably most people don't. You think of it
Right.
as just a thing that happens, and it is what it is. But obviously, sleep has such huge implications on life for everybody. And the great thing is with most of the sleep treatment and the techniques that I use, they're things that can be applied to anybody. I've been able to use what I know to make suggestions for friends and family and for myself. And typically developing kids with autism, doesn't matter. These principles of behavior work on everybody, which is awesome. So obviously not getting good sleep, we know, has pretty bad consequences on your mental health, on your physical health, on your ability to learn. And for me, working with kids in the autism population, if they're not sleeping, it just is ruinous to the rest of their life.
Yeah.
They're already, for the most part, at a disadvantage when it comes to learning and the speed with which they can acquire new skills. So if we add sleep problems to that and they're having trouble staying awake and paying attention, then that's just going to make learning even harder. So sleep can really make a huge difference for those kids in terms of skill acquisition and in terms of problem behavior. There's some really good data out there showing that problem behavior increases when sleep decreases, and not just for kids with autism, but for all kids. So it's something that for me, whenever I get a new client or whenever I'm working with a new family, one of the first things I always ask about is sleep. And if they tell me that sleep is a problem, then that's always one of the first things that I want to take care of. Sleep and problem behavior. But if we can get sleep under control first, that'll make our life easier in working with every other skill.
I like that. That's a very interesting way to go about it. It makes sense, right? You have this kind of setting event that is setting ourselves up for extra problem behavior. I know that, like, in my own day, I'm grumpier when I don't get as much sleep. And then, my problem behavior increases. So why wouldn't someone else's? I actually did an analysis of someone less than 6 months ago where we found this person was living in a group home, and he was an adult. And we found that his problem behavior was correlated with poor sleep. It ended up being a pretty interesting analysis. Sometimes I've kind of run into people who've mentioned, like, yeah, this person really only needs 3 hours of sleep, or yeah, they sleep for 2 hours and then they're up for the rest of the night and they seem like they're ready to go. Have you had that experience before?
All the time. In every type of person that I have ever worked with sleep problems, I get that. So a lot of times I'll hear from parents of kids with autism, well, I've heard kids with autism don't need as much sleep, or my son in particular, or my daughter in particular, just doesn't need that much sleep. I've heard it from parents of typically developing kids. I've heard it from adults who are friends and family. Oh, I don't need that much sleep. I can be fine on 5 hours a night. There's this really great book that I would recommend to anybody who is interested in sleep at all. And it is by Matthew Walker, and it's called Why We Sleep. And it is a really good read that explains the biological process of sleep, but explains it in a really easy to understand way for somebody who is not a scientist that knows about biology. But he does a really good job of explaining the science of sleep and the medicine behind sleep and the biology behind sleep and why it's so important. And he has a whole section where he talks about that, of like, so there's a lot of people out there that'll say, oh, I don't need that much sleep, or I do fine on 5 hours, or this kid does fine on 7 hours. And it is 100% not true, and has been shown by science and by data time and time and time again that when you put people in a sleep lab, adults need an average of 7 to 9 hours of sleep a night. And that is everyone, except for this one very, very, very tiny subset of the population that has this genetic difference, and it's actually a gene that they can test for. And there's this very, very tiny subset of the population that has this gene where they can be fine on 6 to 7 hours of sleep a night, and they won't show any kind of medical or biological deficits from that. But the probability of having that gene is like, I can't remember the statistic that he gave in the book, but it was something like the probability of you getting struck by lightning is like thousands of times greater than the probability of you having this gene. So if you're one of those people that's sitting there being like, yeah, I'm fine on 5 hours of sleep a night, I probably have that gene, it is highly unlikely that you do have that gene. So
none of our listeners have that gene.
Yeah, most likely not. It's like a 99.99999% chance that you do not have that gene, and you do actually need 7 to 9 hours a night. So that's been shown again and again and again in studies that every adult needs 7 to 9 hours. There is that window of time, so that's why they say on average adults need to get 8 hours of sleep a night. Some people fall on the lower end of that, and they're okay on 7 hours, and they don't show any deficits with 7 hours of sleep a night. Other people are going to be closer to that 9 hours a night. I personally I know I'm closer to that 9 hours. If I can get 9 hours of solid sleep a night, I'm great. I'm good to go. If I get 8 or 7, I'm like a whole different person.
I can relate to that.
That's why
absolutely.
I don't have children.
I actually am familiar with Matthew Walker. I think I heard him first on the Joe Rogan podcast. He had this like 2 or 3 hour podcast, and it really changed the way I thought about sleep. It was like pretty dramatic. I was just like, I need to get more sleep.
Yeah. His book, if you read it, it will scare you into wanting to sleep more because he has so much great data in there about what happens to your body when you don't sleep and why people who are consistently not getting enough sleep think that they are and think that they are not feeling the deficits and the effects of bad sleep, and why the same can happen with kids, where if kids are consistently not getting enough sleep, we might look at them and not actually see the effects of it because it sort of accumulates in a way that now you just get used to the way this child is acting, but they're not actually at their full potential. So there's a lot of really good data out there showing exactly how many hours of sleep people need per night at different ages. And no matter what anybody wants to tell you or how much they want to argue that is not true for their child, it is definitely true. And same with kids with autism. There's some new interesting data coming out with kids with autism that there are definitely differences in sleep, and they seem to be some kind of biological differences with what's actually happening with their brain during sleep. But as of right now, there is no definitive, I guess, answer that kids with autism don't need as much sleep. They often don't get as much sleep as their typically developing peers, but that doesn't mean that they don't need that same amount of sleep. It just means that they usually have more skill deficits in the area of falling asleep and staying asleep.
Okay, that's interesting. So it might not be necessarily related to the diagnosis, but more just related to skill deficits.
Yeah, that's what I think. In general, kids with autism don't sleep as well as their typically developing peers, and there's a lot of good data showing that. Their rates of sleep problems for typically developing children are pretty high in and of themselves, but the rates for kids with autism having sleep problems, I've seen estimates as high as 90%, which is astounding to me. If 90% of kids with autism have sleep problems, how are we not doing more about that as behavior analysts who work with that population?
Yeah, absolutely.
I'm sure anybody listening to this who works with kids on the autism spectrum probably can name more than one of their clients who has sleep problems.
For sure.
Yeah, that's a great point. And I think that speaks to one of the reasons why it's probably important that people maybe learn more about it and kind of try to add that to their list of skill sets that they're competent at delivering, right? You mentioned the book. What are some other resources that if a practitioner was interested in sort of learning more about it and wanted to become more competent in the area of sleep treatment, are there things you would recommend they check out?
In my experience, there's not a ton of great resources that are specifically for behavior analysts wanting to treat sleep problems that really go into how to assess sleep as behavior and how to then tailor treatment from that. That's why I was so fortunate to have been in Greg's class and get that instruction from him, because he does have a really good means of doing that with the sleep assessment and treatment tool, and kind of pulling together a whole bunch of research and then using that to develop that sleep assessment and treatment tool, and then using that tool to then create treatment. I know he occasionally does some sleep related workshops and trainings. I don't know what he has going on currently because I haven't been paying super close attention to that. I've been offering some webinars and some trainings on treating sleep problems that are designed for behavior analysts.
Oh yeah, that's great.
So that's something that I have been trying to put out there more because I know there's a huge need for that and a huge interest in that.
Cool.
If that's something that people are interested in, then I can give you guys my email, and anybody who's interested can email me, and I'll add them to a mailing list that I have for
great.
continuing education opportunities, which right now are mostly centered around sleep and anxiety.
Cool. Yeah. So is it appropriate for us to put your email address in the show notes?
Sure.
So we'll do that, and then
fine.
people can grab it. And then you have a website, Facebook page. I know you have a Facebook page.
I have a website, but right now none of my continuing ed stuff is on the website.
Okay, yeah. So we'll put all the links related to the things that you're doing and offering right in our show notes so people can grab them. Hopefully this podcast episode will just serve as a little bit of an introduction to the stuff that you can offer in those webinars. So I bet people will
hope so.
Yeah, people will be really interested in that.
Hey, sorry to interrupt, but if you're a BCBA or BCABA and interested in getting a CE for listening to this episode, you can head on over to functionalrelationspodcast.com and purchase that. This episode is worth 1 learning CE, and you'll need to provide 2 code words when you go to checkout. The first code word for this episode is burner. 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 As in, when I make mac and cheese, I put the pot on the burner. Burner.
Yeah, the cool thing with treating sleep problems is as long as you understand the basics of how to assess sleep as behavior and the basic things that we use to treat sleep, it's in my opinion, a pretty simple formula for developing sleep treatment and developing treatment packages that work and that are pretty easy to understand and pretty easy to explain to parents and teach parents how to do. So it's one of those things that kind of once you understand it and once you know how to use that sleep assessment and treatment tool to inform your treatment, it's not too difficult to go from there and to be able to apply that to multiple different clients and even to your own sleep or to friends or to family.
Cool. Yeah, that's an interesting point you say about your own sleep, because I feel like every single thing I read about sleep, I'm like, well, I need to do other things like in my own life, in addition to like how you could help use it in practice. It kind of sounds like if somebody's interested in learning more about this, step 1 is maybe find somebody that can teach you, like either through like a workshop or like a webinar, like what you're talking about. Would you agree with that?
I think so. I think it's a little bit difficult to wrap your head around assessing and treating sleep as a behavior problem until you really understand the sort of conceptual analysis behind it, and then also how to use that sleep assessment and treatment tool. And then once you get that and you understand, there's basically 4 main areas that we look at when we're treating sleep problems, and it's a pretty, I would say, relatively simple thing to figure out how to treat each of those things once you understand how to figure out what they are and assess it. But always the best way to tackle a problem that you've never tackled before is find somebody who knows how and learn from them.
Absolutely.
And then kind of set off on your own with a little bit of feedback and a little bit of help. And then the more you know, then you can help other people.
Yeah.
That makes sense. Yeah. So let's say that somebody, they go out, they attend a webinar or something like that. They learn about how to use the sleep assessment and treatment tool. Once you're actually up and running and implementing treatment, are there common problems that you've seen in practice that might pop up as you're actually implementing things?
I have had surprisingly really, really good success with sleep treatments that I've done. I think that's the reason why I enjoy treating sleep problems so much, because it's really reinforcing for me to see really quick results for clients and to see them be really happy. And it's really reinforcing for parents when they see something work really quickly, and just to see what a difference that makes in their lives and in their kids' lives when they're sleeping better. The few cases that I've had that haven't gone well or that we haven't had a good outcome were either when the child had behavior problems that were too difficult to manage to be able to successfully implement sleep treatment, and we needed to go back and tackle the behavior problems first. So, for example, I had a kid with really severe self-injury that when he was left alone at night, he was engaging in self-injury, and there were too many confounds with trying to get the parent out of the bedroom at night, but also trying to make sure we were safely managing the self-injury. So we ended up having to go, okay, we got to take a time out on the sleep.
Yeah.
That's not the important issue right now. We got to go back and tackle behavior problems first. And then the other main problem that I run into is that parents just aren't ready or don't have the resources to be able to do the sleep treatment at the time. So I've had a few times where parents have come to me and been like, yeah, I want to do this sleep treatment. And then we get into day 2 or 3, and it's just like one obstacle after another where it's sort of like, okay, this isn't really a problem, but you're making it a problem, which shows me that you're probably not ready to do this right now. And I find the biggest hurdle usually is parents that are co-sleeping with kids, and they realize it's a problem, but at the same time, they are not ready to let that go yet, or they are not ready to be sleeping separately, even if their child is. So when we go to start treatment, it's not the kids that are having a problem with sleeping alone, it's the parents that are having a problem with kind of separating. And that's totally okay. And I tell parents, like, hey, if this is not the right time to do this, or you're not ready to make these changes, that's okay. We'll leave it for now, and we'll come back to it when you're feeling like you're ready and you have the resources and you have the energy and you have the time to commit to this. So it's often a problem of parent adherence, but it's because there are other factors going on where they just aren't in a good place to be doing that kind of treatment at the time. And that's fine. Life happens. Sleep treatment is a bit of a, you have to commit to doing it and commit to a couple weeks of putting the work in to see the results. And sometimes timing is just not good for that.
Yeah, absolutely. It's tough because you're in a spot where you're tired and trying to implement a treatment, and that's hard. I mean, it's hard to do it when you're not tired, but then in the middle of the night or trying to adhere to something in that stress state is just, I think, ups the ante a bit.
Yeah. And for me, with writing sleep treatment programs, it's as much about assessing the parent behavior as it is about assessing the child's behavior and thinking about, okay, why is the parent doing the things they're doing, and what are their reinforcers, and how is this going to feel for them, or how does this affect their life and their reinforcers? And you have to really think about that, because sleep treatment, when I do sleep treatment, it's not me going in there and doing the treatment. I don't have the time or the energy or the resources to spend the night at somebody's house and to do the treatment for them. So sleep treatment is parents doing the treatment, which means they have to be well trained. They have to be ready to do it. They have to have the energy to do it. They have to have the resources. They have to have the time. They have to have the patience.
Yeah.
So I try to really stress that whenever I take a new client. I tell them this is going to be work for you. This is going to be difficult for a week or two. It usually, honestly, it ends up being difficult for a night or two, and then once they're in the swing of it, it gets significantly easier. But I try to really make sure that the parents are prepared for that and that they're ready to put the work in if they want to do it.
So if you're ready to run this protocol, maybe you've looked up the Pat Friman article and you say, oh, I'm going to use the bedtime pass, and you get out there and you're working on it, or maybe you're working on some sleep fading away from the parents into their own room or something. What are some common modifications to the things that are already found in the literature? Have you had to modify anything to make it work for a particular family? Or
one thing that is going to sound really silly, that is a modification on the bedtime pass. I often have parents make their own bedtime pass and laminate them, because you can't give a small child a paper pass because it ends up getting destroyed within a night. And we learned very quickly that if they're going to laminate a bedtime pass, they have to make rounded edges, because if a kid is sleeping with a square-shaped bedtime pass with pointy edges, they will wake up with scratches the next day. So, sounds silly, but an important
that's a pro tip right
rounded
there.
Edges, yeah. In my experience, the bedtime pass is not always successful with kids with autism. You definitely need a certain level of verbal understanding for that one to work, and for rule-governed behavior and understanding for that one to work. If they don't really get the rules behind the bedtime pass, it's going to be a waste of your time and effort. So that's one that I reserve for specific types of kids that have a little bit of an understanding of quantity of things and number and delayed reinforcement. So it takes a bit of a higher functioning child for that to be successful. I've also found that's not super successful in kids under the age of 4. Some 4-year-olds might get it, some might not. So I tend to reserve that for a little bit older and higher functioning kids, or typically developing kids.
Makes sense.
As far as the other, like the fated bedtime, I tend to run that pretty close to what is in that original article. In the Piazza and Fisher 1991 article, The Fated Bedtime with Response Cost, I don't use the response cost portion of that protocol usually because I haven't found the need to.
Okay.
I have written it into programming before, but never had to actually use it. So basically with that, all you're doing is you take some data for usually a week or so on what time the child's actually falling asleep. And then when you start sleep treatment, you actually push their bedtime significantly later than when they're currently falling asleep. So let's say on average, they're falling asleep at 8 p.m. When treatment starts, you might bump the bedtime up to 9 p.m. so that when you put them in bed, they're tired and they hopefully fall asleep right away. And the response cost portion of that is if they're not asleep within X number of minutes, you pull them back out of bed for an hour and you don't let them go to sleep and you don't let them go back to bed. I find for parents, the response cost part is pretty difficult to implement and asking a lot of them. So I typically don't use that. But usually with just the fated bedtime, I find kids are so tired when you put them in bed, they tend to fall asleep pretty quickly. Aside from that, I think, as we do with pretty much any training, you have to individualize your treatment, not only to the child, but to their parents and whatever resources they have and what they're willing to do. So whenever I write sleep treatment programs, I always pass a first draft to the parents and I ask them to read it over and say, okay, what do you think is going to work in this for you? What do you think is not going to work? And anything that they even think is not going to work, I'll take it out, because if they are not on board, it's not going to happen.
That's good
it's
advice.
them that has to do the treatment.
Absolutely. That's great advice.
Keira, I have a question. You've been talking about how when you implement sleep treatment, it can be kind of an intensive process, at least for like a week or two. Do you have any suggestions for maybe practitioners that maybe they have a case of a student that maybe has like delayed sleep onset, or when they wake up in the middle of the night, they don't fall back asleep, and maybe the parents can't implement an intensive sleep package, or maybe I'm thinking of when I've worked in residential programs where maybe there just isn't staffing to implement a intensive sleep treatment programs. Is there like some general like guidelines or suggestions that might be helpful in promoting just good sleep habits in general?
Mm-hmm. Yeah, the things that I tend to focus on are keeping a consistent bedtime routine. And it doesn't have to be anything too complicated or anything too like long in duration. As long as the last 10 or 15 minutes before bedtime is consistent, just having that routine alone can be really helpful, because then you have a consistent chain of events that's leading up to that period of what they call behavioral quietude and falling asleep. So you think about it like setting up any other chain. You want each step in the chain to occasion the next step. So if you have a consistent chain of events at night that's happening before bedtime, that actually helps to occasion falling asleep. So that's one easy thing that, regardless of staffing or how much time the parents have, people usually have this little bit of time before they're putting their kids to bed at night that you can start to incorporate a regular bedtime routine. With that, definitely keeping away from extra light, and blue light in particular is really helpful. I know everybody always hears about that, but that actually really does make a big difference on sleep. And the reason for that is that melatonin production, which is a hormone that makes you sleepy, that is actually triggered by light. So us humans and all of our artificial light, we've really disrupted that process, because our eyes are getting flooded with artificial light all the time, and that actually inhibits melatonin production, which can inhibit falling asleep. So if you can just dim lights and get away from your screen at night, even if it's just the last half hour before you go to bed, that can make a really big difference. And that's something that is not a huge ask for most parents and families and staff. The bedtime fading is also really successful, but that can be a little bit difficult in like a residential setting. It can be a little bit easier for parents to do if you say, hey, just for this week, keep your kid up an extra hour and then try and put them to bed when they're sleepy. So there's some little things like that. When I do sleep treatment, where we're doing sort of a whole overhaul sleep package, it's basically combining a lot of those little things and saying, okay, we're just going to hit it with all these things at once. And sometimes it'll be, it's a little bit of a learning curve because it's a lot of changing the parent behavior and what they're doing at night. But usually it ends up being a lot less work than what people think it's going to be. And it's usually maybe the first 2 or 3 nights, things are significantly different than what they've been because I'm asking the parents to keep the child up later or go in and do repeated checks where they visit the child's bedroom over and over again until they're asleep. So sometimes there's some weird things like that where I say, okay, it's going to take some work. It's going to take some following the protocol. It's going to be a bit of a disruption for you. But for most parents of kids with sleep problems, it's already a disrupted time at night anyway. If your kid's already not going to sleep, you're already running around and doing all these things anyway. And most parents have told me like, oh, that was actually way easier than I thought. Because in their mind, when they hear sleep treatment, they think back to like the 80s when people used to do sleep treatment and go basically lock your baby in a room and lock the door and let him cry it out. And you have to stand outside and be miserable all night. And that's not at all what we do. We don't want that to happen at all.
Right.
No, that's awesome. And those seem like really helpful tips. Is there anything else that you haven't talked about as it relates to sleep treatment that you feel like would be helpful for people before we end today?
I think just on a sort of more general note, I always use the sleep assessment and treatment tool as part of my assessment. I also have parents take data for a week or two before we start sleep treatment. That can be really difficult to get parents to adhere to data collection or to do a good job of it. So you always sort of have to take any data collection you get with a grain of salt, that it might not be the most accurate. It is a little bit difficult and sometimes distressing as a behavior analyst to have to rely on parent data for assessment and for treatment because, like I said, I don't have the resources for me to be in the home at night every night. Some people may have that, and that's great. So it can be a little bit tough for me because I feel like sometimes in treating sleep problems, it's a bit of what to me feels like sloppy behavior analysis of I can't take data the way I want. I can't necessarily manipulate variables the way that I want. So it's more of a general understanding of how sleep works as behavior and how we can manipulate environmental variables. And then we don't necessarily need to know every little detail where like we have to do a functional analysis on this thing and we need ABC data on this. It's more of just, I need to know approximately when your child's falling asleep, how many hours of sleep are they getting? Are they waking up a lot at night? And then I can give you this comprehensive sleep package with a whole bunch of different things that should work. I might not be able to tell you specifically which parts of that package worked and which parts didn't, but as long as this package as a whole is solving your problem and everybody's happy, then it's good.
Right.
And it feels, it sometimes feels a little unsettling to me as a behavior analyst to not be able to always get the data that I want or not be able to pick apart a treatment the way that I want. So I would encourage people, if they have the resources, do that. If you're able to take data yourself, or you're able to set up cameras or do any of those types of things, or be the person in there implementing the treatment, great. We need more data on all of these things to figure out what really works and what doesn't. And we need more research on all of these things as well. But for now, we work with what we have and do the best we can for our clients to actually see results and see them quickly and fix these problems.
It seems like technology over the last few years has come a long way. Do you ever use like Fitbits to track sleep and things like that for the clients?
Yeah, I haven't recently with many of my clients, but I have had some parents do that. If you have a kid who's already using things like that and they're comfortable going to sleep with something like that on, great. If they're not, then I don't usually recommend parents buy that for that purpose because, as we all know, kids with autism tend to get very stressed out by wearing things that they're not used to wearing or things like that. But yeah, there's a lot of really great apps that take sleep data, Fitbits and things like that can give you some pretty good data. There's different apps on your phone where you can just stick your phone under your pillow and it takes some data. I don't know how reliable those are, but they're there and it makes it easier. And now there's so many different things like Nest cams and nanny cams and things like that actually make it easier to get data collection via video.
Neat.
Kevin Luzinski just came out with an article not too long ago where they looked at different video recording methods. So there's been some good breakthroughs in technology with that. I would say I don't rely on that stuff much yet in my practice because there's still a lot to figure out with that.
Yeah.
But I think someday, pretty soon, we will have a lot better technology in that regard.
Yeah.
I feel like parents report, as far as like when you have something that's working, could be some pretty valuable data, even though it's maybe not the hard data we like. Like if a parent's like, I had a great night's sleep last night, and that's because my kid was like out all night. I feel like that might be some good treatment efficacy data, even though it's not like, minute by minute. Like it's probably a pretty reliable measure, I would guess.
Yeah, exactly. It definitely, it kind of can bother me sometimes being like, I don't have the graphs that I wanted. I don't have the data that I wanted. I can't really pick apart the parts of the treatment that are working, and I can't do like a return to baseline because the parents will never agree to taking this stuff away once it's working. So for the research part of me that wants to do all those things, it's hard to not be able to do that. But for the clinician part of me, being able to see really fast changes in behavior that are long lasting. And usually if I have clients that when we've wrapped up sleep treatment in a couple weeks past when we started, I'm not really hearing from them anymore and they're pretty happy and things are going well. Usually if I ever receive a follow-up, it'll be a couple months down the road and they'll say like, oh, we're kind of going back to where we were before and the child's not sleeping well anymore. And I say, well, what are you doing? Oh, well, we're not really following the sleep treatment quite right anymore because they just had vacation and we did this thing and now they're sleeping in our room again. I'm like, okay, go back to that treatment that I wrote and start doing that again. And then 2 or 3 days later, I'll get a call. Oh yeah, no, we're good now.
We got it. Yeah, great.
So it's great. It's one of those things that like you can just direct them right back to that same treatment when problems pop back up again. And usually the same treatment solves the same problem. So sometimes we get a nice little reversal design there, which is nice for my inner researcher. But one other book that I forgot to mention that is great to check out is by Pat Friman called Good Night, Sweet Dreams. I Love You. Now get in bed and go to sleep. And that's written
That's awesome.
a bit more for parents. And I often recommend that to parents as a really palatable. It's written like Pat Friman speaks, where it's pretty funny to read and pretty entertaining and a lot of really good information too.
Nice.
That's awesome.
That's a good resource. Yeah.
Yeah.
Well, thank you. Thanks a lot.
Thank you guys. Thanks for having me.
And we're back. This is the time in the episode that we've decided to set aside time to show our appreciation for all the people who support us and the podcast.
Yeah, we had a lot of support. In fact, we had a few Patreon members join just this past month, so that has been very encouraging. We really appreciate those folks. Thank you again. We received support in a lot of different ways, actually. Some people, it's become Patreon members, and other people, they help us out in other ways, right?
Yeah, and definitely we appreciate the people who take the time to give us reviews on things like Apple Podcasts or iTunes. And also, if you take the time to post on our social media accounts, like Facebook or Instagram, or email us, we definitely appreciate all that stuff.
Yeah. If you want, you can email us at functionalrelationspodcast@gmail.com. That's a good place. We respond pretty quickly, for sure, I think. That's something we're pretty good at. We're not like those professors at the university you can never get in contact with. We're here for you anytime you want.
That's right. And if you are somebody that's maybe interested in supporting us in more tangible ways, feel free to support us on Patreon. Zach, can you tell people a little bit about Patreon?
Yeah, well, so Patreon is a website that allows members or listeners to access behind-the-scenes posts or bloopers or updates as we get going. and we send out small gifts to them to show our appreciation. If this is something you might be interested in, feel free to drop by patreon.com/functional relations podcast. We're going to put it in the show notes so you can feel free to take a look.
Yeah, we don't want to keep people away from the content of this episode very much longer. But again, we just wanted to make sure that we've thanked everybody for your support and letting you know that we couldn't do this without you. All right, so let's talk about the interview. I thought it was an excellent interview on a really interesting topic.
Yeah, I love sleep treatment. It's just an interesting topic to me. And so I'm really glad we did this episode. And I'm really glad that Dr. Keira Moore came to join us because she was a wealth of knowledge. Yeah, it was just a great, fun time to have her on the show.
Yeah, and I think one thing that was very apparent, and I thought she provided some really good information around this, was like why sleep is such a big issue and why we should be working with this as behavior analysts, right? Like, I think we talked about like how maybe not a lot of people have had a lot of training around this, but then when you actually think about the statistics and like how many people have sleep problems, it's overwhelming.
Yeah, it really is. And it's surprising that, there aren't more behavior analysts getting involved in this as a problem, because when you think of how many folks have trouble with falling asleep and staying asleep, I really think the behavior analysts should get in the game a little bit more. So when we think about resources for this, what did you think about, Caleb, as far as kind of primary resources for people who would be interested in learning more about sleep treatment?
I think the biggest resource is from, some of the work that's come out of like Greg Hanley's group. I know the sleep assessment and treatment tool, which Keira mentioned in the interview, like that's the big one. That's the one that I've heard of. And it's a pretty good tool as far as like organization and the actual assessment. And then it kind of gives you some good information about how to proceed with treatment.
Yeah, I've used that. I had a sleep consult just a month or two ago, and I used the tool along with some other resources. And I do feel like this is a very important thing. If anybody listening has not used this tool but is interested in doing sleep treatment, please check out the link. We're going to link to it because it's free and available to people, and it's just a really nice resource. So that's a good one. I also had, when I was doing my sleep consult, I was using a review called Interventions for Infant and Toddler Sleep Disturbance. And this is a review by Brett Kuhn from the year 2000. So it didn't have the sleep treatment assessment tool in it, but it did have a great, we talked about how there seemed to be a lot of sleep treatments developed in the 1990s. Maybe it had to do with Nintendo coming out or whatever. I don't know. But this is a review of basically all the research in the 1990s. Came out in the year 2000. So this was another really valuable resource that used, I think, in combination with the sleep assessment and treatment tool can be really valuable.
Yeah, I mean, it seems like we have different types of resources, right? We have like papers that kind of provide description about like treating sleep problems and things like that. But then we have the sleep assessment and treatment tool, which is essentially something that you can pick up as a clinician and essentially use it to develop a treatment, right?
That's right. Another thing, I think a good resource that Keira left us was that she does webinars, and that could be a really valuable thing for people.
Yeah, and I think if that's something you want to do, as in like you're interested in learning more about this topic so then you can go about and develop sleep treatments, it's probably worth the time to do a webinar or some sort of training, just because it's something that not everybody has had training in. And so to kind of like add it to your arsenal of things that you're competent in, it's probably worth the time to do like a webinar or a workshop or something like that.
Yeah, absolutely. I don't know about the sleep webinar because I haven't taken this one from Keira, but my wife, who's also a behavior analyst, she just took Keira's webinar on anxiety and was like pumped about it when I think she even talked to you about it, Caleb, didn't she?
Yeah, she couldn't wait. She liked it so much. Yeah, she decided to tell me all about it, which, yeah, it sounds great. We can assume that the sleep webinar is just as good.
Yeah. Caleb, I thought you made a really good point about data collection. We were all talking about data collection and how, as behavior analysts, we always, strive to get the best data possible. But you kind of said like, yeah, well, the thing about sleep is that I think you could probably ask the parent, like, did you have a good night of sleep? And if someone's like, yeah, I slept the whole night, then you can assume that your treatment was really effective because presumably that wasn't happening before you started treatment. So I think that that's a really good point. I think we can make data really a lot simpler. Then we don't have to make it super complicated. We're having parents collect the data. So do you have any more thoughts on that? I thought you had a really good point. I want to know if you had any more thoughts on that.
Thanks. I appreciate that. Now, it kind of reminds me from season 1 when we had the episode, and I think it was with Dr. Bob Ross. He said, he made the point about we're the ones who get paid to collect data. And, when you're like working with families and stuff like that, maybe we shouldn't expect as much, and kind of paraphrasing what he said. But I think it rings very true when you think of sleep, right? Because we're asking somebody to implement an intervention during a time where it's probably like you're least likely to want to implement an intervention, right? It's probably like later at night, you just want to sleep. Parents have busy lives. They're tired too. And so maybe we should focus more on supporting them to implement the interventions and not being as concerned with data. That I know as behavior analysts, we like our data. We need those data. But maybe thinking of like how we can get data in a way that is more easily had or collected by parents.
Yeah. And I think I used just like call outs as the primary data that I was collecting for the sleep consult because, really, I don't know, unless you're just watching someone all night long, you really don't know if they're sleeping. But the idea is, I mean, you can check on them to make sure they're falling asleep within 15 minutes, basically, or whatever. But you're not going to be like watching them all night. So maybe they are staying up and whatever, but probably, as long as you can get the call outs down, kind of the things that they were doing instead of sleeping, if you can get rid of those, they'll probably be sleeping again.
Yeah, maybe figuring out what is doable, right? Because checking on a child like throughout the night, like it's probably just not going to happen, right? I mean, I think that I don't know that that's necessarily, yeah, it's not necessarily like a reasonable expectation, but yeah, I don't know. I think it's doable, as in I think sleep treatment is doable, right? But one thing that Keira mentioned that I think is important, and I think it ties into the episode earlier this season on Ruby, is making sure we're upfront with families about like the expectations of implementing an intervention.
Yeah. Mm-hmm.
You know what I mean? Like somebody should know, like, hey, sleep treatment, it's going to require like for a week or so, pretty intensive stuff. It's not probably going to be easy at first. And so making sure people can take that on, right? Because maybe they're not ready. Maybe somebody's not ready at this time to take on an intensive intervention, and that's fine. But I think you want to be upfront about the expectations and make sure somebody's ready to take that step before kind of embarking on that.
Yeah, I think that's exactly right. One other thing I just want to bring up before we kind of close it out was I think I was hesitant to jump into treating sleep problems because I was afraid I was going to be up all night. Like I thought it would mess with my own sleep schedule. But really, the way you can do that, I think. And maybe there are times that you need to kind of be in the moment coaching them through. Maybe you do it over video chat or whatever. But I think for a majority of sleep problems, they're easier to solve than maybe you might think they are. And what I do is I show the family the treatment and create a situation where there's like behavioral skills training on, okay, this is what happens when she wakes up. This is what happens when she's, calling out, or this is what you need to do in this situation. And once you go through that and you kind of make sure everybody's fluent in what they need to do, it's been successful. So I hope people aren't feeling like they shouldn't get involved because they don't want to mess with their own sleep schedule. That's something that was kind of a barrier to me, and that's kind of been alleviated as I've done them. So
yeah, that's a good point. So you can still use things like behavioral skills training and like the normal ways you would train people to do things without necessarily needing to be there, and maybe offering some other way of like support or something like that, right? So when you've done sleep training, how do you offer like support to families, like knowing that you're not going to be there?
Yeah, so primarily I kind of go through the assessment phase. I come up with some sleep options. So I try to do this with everyone, but basically I don't try to say like, this is what we're going to do. It's kind of like, here are the pros and cons of this. If we use an extinction-based procedure, it might work faster, but it'll be harder to implement. If we use kind of a fading procedure, it'll be, take longer, but it'll be really easy to implement because we're just going to make these really small steps and you probably won't see as much problem behavior. And, we kind of together decide what's going to be best for the family. And then I write up the plan and I do the behavioral skills training during the day on what they should be doing in these different contexts. So I kind of think of like, what are the contexts that will probably be occurring and run people through them. The kids like it too because they get to role play, and I even let them role play crappy behavior. So they're like, get to like pretend to wake up their parents and all that, and it's kind of fun. Usually, you can
that's
make
cool.
it fun.
So you include like the client in the role plays like that.
Yeah, absolutely.
Okay.
If I can. I mean, some people you can't, but
Yeah.
I think a lot of times you can, and they can have fun with it. And then once everybody's comfortable with what they're going to be doing, what is expected of them, I let them run through it. And so they will, the next day, they give me a call or send me a text, say, how'd it go? And then they'll tell me, oh, it was okay, but, blah, blah, blah. And then, you work through the issues, and usually a few tips here and there, and then people are on their way. I think Keira was right about how it's easier than people expect. Hey, everyone. If you've been listening to this whole episode and you're interested in getting a learning CE, the second and final code word is slice. 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 Like, hey, give me a slice of that orange. When you finish the episode, head over to functionalrelationspodcast.com to purchase your learning CE. Oh, and also, if you're in need of ethics CEs, you can get 2 ethics CEs for any one of our episodes from season 1.
Yeah, and I think similar to like what you do, Zach, you said that you give families options. She said that she'll like sit down and review like the first draft of the treatment plan with the family just to make sure that it sounds like they can do it, right? And if they're like, oh, actually, we don't think this part we can do this, then she kind of factors that into the plan, which it sounds like similar to like what you do. You're not like, oh, we're going to use extinction. Good luck, right? You don't do that. You kind of like explain the options and see what will work for the family, right? Because what one family can do might not be what another family can do just based on like resources and like the way that what's going
family
on
dynamics
in the home.
and absolutely. That's right. So we have some resources, we have some tips, we have some reminders, we have some ways to get training. Anything else we should hit on with this topic, Caleb? You feel good about it?
Yeah, I feel good about it. Hopefully this is helpful, kind of like an introduction to sleep treatments. And, like you said, there are resources available. There's workshops, there's webinars, there's things like that if people want to learn more about it and build up that skill set so they're able to start conducting sleep assessments for their clients.
Yeah, and we're going to put all the resources down in the show notes, so make sure you browse those. Those are really valuable if this is a topic that's interesting to you, because we take all the resources and put them in one place. So I hope that's helpful to you. And what else? So yeah, jump on Facebook and follow Dr. Keira Moore. She has updates on her Facebook page. I see them fairly often about kind of sleep tips and some resources that she gets along the way. And you can jump on her mailing list. You can send her an email. She has her email address right in our show notes. So use that if you're interested in learning more.
Yeah. All right. Well, I feel like that was a very interesting episode, and I hope everybody else enjoyed it as well.
Yeah. So you can purchase a learning CE for this podcast at functionalrelationspodcast.com, or you can become a member on our Patreon page at patreon.com/functionalrelationspodcast. And we'll see you in a month. So see you then.